Hi, it's the nursing professor here. Today I want to talk to you about something very, very serious and prevalent, especially in minority people, and that is colorectal cancer. And March happens to be the month in which we celebrate the awareness of colorectal cancer. And so let's start off with a review of the GI system. So it starts at your mouth and it ends in your rectum. So anywhere in between that 30-foot space, an obstruction can occur, or a dilation of a vessel, or something can occur that can make you more susceptible to having cancer. So cancer develops in the colon or the rectum, and that is why it's called colorectal cancer. And it disrupts the normal bowel function. And so that might mean that the person starts to complain of constipation, or they might start to complain of diarrhea, or a combination thereof, or they might notice that their stool is even really slim or thinner than normal. And all of those could possibly be a sign of cancer. And one of the most prevalent ones that people are able to pick up on is blood in their stool. When they start to see visible blood in their stool, then usually that mass or that disease process has already started and has been there for a moment. But we must remember that it is curable by 90% if it is detected early. So let's talk further about how we can teach our patients how to report symptoms that may save their lives. All right, so we have some tools like Cologuard. You might see the little man on TV in a box and little arms waving around. Cologuard actually detects colon cancer by looking at the DNA of the stool. So it's a self-administered test. They take the box home. They're able to test a stool sample and they send it back to the lab. Another more convenient way is doing a test of fecal occult blood. And that's a little card where a person puts a sample of 2 spaces of their stool on that card, and usually they mail them back into their provider. The provider then checks for blood in their stool, blood that's not visible. Those are usually done once a year. What is recommended over the age of 45, so 45 and above, and even earlier if there is a family history, around 35, is a person has a colonoscopy. Colonoscopies are when there is a camera directly inserted in the colon, and it actually takes pictures of possible disease processes that may occur, and they are frequently known as polyps. And when they see those polyps, the camera is able to have a little device on it to actually remove those polyps, and they are sent to the lab for further testing. So a biopsy can actually be done to determine if that person has colon cancer or not. So that is the most reliable type of colon cancer testing that there is. But the problem with that, and many times why we don't have our patients be compliant with it, is the PrEP. The PrEP is usually something like GoLYTELY or some sort of fluid that they have to drink a gallon of. It doesn't taste so good. However, again, because it's 90% curable, then early detection is the best bet. So let's talk about what can possibly happen with this colon cancer. You can end up, or a patient can end up with dehydration, electrolyte imbalances, and malnutrition. And frequently this shows up as weight loss. And what happens is the colon is no longer able to absorb the nutrients. So a person is just eating and they'll find that literally they're just dumping out the waste. Another way colon cancer can form is from the toxin buildup. And these are people who usually have a mass where this mass prevents them from going to the bathroom. And so therefore they're severely constipated. They can even have an entire obstruction where they're unable to go to the bathroom. And usually the patient will present with nausea, vomiting, burping, not being able to pass gas, and usually belly distension because they're so miserable. But of course, if you can't pass the waste, then you're going to end up toxic from that. You can also end up with perforation of the bowel, and this is when small tears or holes actually happen in the intestine. And so, of course, if there's a hole or a tear there, then that waste can empty out into the peritoneal space or the abdominal space, and you only can imagine how infectious that can become. Last is metastasis. Sometimes colon cancer goes undetected for such a long period of time that those masses start to grow, and they can grow to spaces in the abdominal cavity, such as the liver or gallbladder or pancreas, or even the peritoneal space. And so those cancers are a lot harder to cure. So this is why we want to impress early detection. So let's apply all of that GI reminder to the nursing process. All right, so A, assessment. So what we're going to do is we're going to gather information from our patient. We're going to ask some questions about their family history, get subjective information from them, get objective information from them. And what do you think objective information might be? You can listen to bowel sounds, right? And so that can also give you some idea if the bowel sounds are sluggish or hyperactive or not. You want to listen to symptoms like if they're complaining of fatigue or weakness, diarrhea, constipation, actually seeing blood in their stool, or that they notice that they have really, really bad belly distension, okay? And you want to know their family history, because family history becomes very important when we're trying to look to see if a person might need screening a little bit earlier. So then we move on to our D, where we come up with a nursing diagnosis. And of course, that's going to depend on those symptoms. But we can have things such as alteration in comfort if the person is experiencing pain, fear and anxiety, because many times people have these symptoms, but they really are afraid to report them to their provider. And so therefore they suffer through it. And we can have risk for many things, like risk for electrolyte imbalances if the person's not reporting it and they're having problems with absorption and things like that. We come up with a care plan based on our assessment and our nursing diagnosis, and then our interventions. Number one intervention is always education, because again, people are so, I guess talking about the GI system is pretty private, but they're so not comfortable with talking about their bowel patterns, and we need to make that more normal, such that they will report if something is unusual or not. We're going to teach them about the various screenings, making sure that we let them know colonoscopies are the best way to screen, especially if you have symptoms, and that if you're cleared on your colonoscopy, usually you're good for 10 years. But if they find something suspicious, you might have to repeat it in 5 years. You also want to make sure that you're educating them to drink all of the prep, because if they don't, then the provider won't be able to see anything. And I can't tell you the number of patients I've seen sent back because the bowel was not cleansed, and therefore they could not visualize whether or not something was going on or not. We can provide emotional support to them if they really are feeling uncertain or afraid, again, of what might be. We want to impress upon them the importance of following up after they have their procedure. If they're very resistant to a colonoscopy, we want to go with some of those more acceptable ways that we find with patients, like Cologuard or the FIT test or fecal occult blood testing, because they are a lot easier. They don't require any preparation, and people are usually more amenable to that. And last, we want to tell our patients to make sure that they follow up with those results, because sometimes people will get testing and they don't go back to hear what the results are. So we want to make sure that they follow up. We want to make sure that they have the adequate support that they know the importance of seeing a specialist if something suspicious is found, and to let them know that really early detection at this day and time provides a 90% cure rate. And so therefore they should not be as afraid that, God forbid something happens, that, the likelihood that we can manage this disease with them is pretty great in today's time. So I hope that helps. Bye for now.